Let's see. All right. So welcome to week two. Um, yes, Brittany, I got you. Yep. Um, so just as a reminder, there is still one more exam review that you live review that you can extend. Oh my gosh, that you can attend before next week. It is, excuse me, it is Friday at 4:30 with Professor Foster. So if you have not had an opportunity to attend the live review, you still have an opportunity, excuse me, to attend one. Um, if not, as they come in, the recordings are posted in your announcements. I've also posted your group assignments, so you have those along with your topic for your group, um, so that you can start working on that. Remember we had that whole thing about procrastination, so figured I'd get that out to you as soon as possible. Um, so before we get started, does anybody have any questions for me thus far? I know it's only week two, but figured I'd ask if there's any questions. Anybody need any clarification on anything um, as of right now?
Um, Professor, can you please clarify about the project on group? What is we have to follow certain structure or
So all of the instructions are in there. So instead of the poster,
Mhm.
remember you're gonna do a PowerPoint presentation. Okay, so
Okay.
um, all members of the team have to participate, both in obviously pulling the information together, um, and then as part of when we do the presentation, everybody has to participate in the presentation as well. So everybody has to
Okay.
have a part in that.
Okay. Okay. So we do the presentation and we are going to present and everybody have to okay. Okay.
Yep, you'll present during class via
Mhm.
Zoom, and everybody will present their group project, and each person in the group is gonna needs to present part of the project.
Okay. Thank you.
Absolutely. All right. Anybody else? Are we good so far? Okay. All right. So today we have chapters 6 and chapter 7. So in your success in practical vocational nursing. So chapter 6 is ethics. And then chapter 7 is going to be nursing and the law. All right, so I will share my screen so you can see the nice PowerPoint. Okay, I did something to my chat earlier and I thought it was going to fix itself, and apparently it did not. So I'm going to move it. I don't know what I did. I move it out of the way. All right. So ethics. Okay, so when we think of ethics, um, ethics, sorry, I'm interrupted by my dog. Ethics is a system of standards or morals, or standard or moral principles that direct actions as being right or wrong. Okay, so it's concerned with the meaning of words like right, wrong, good, bad, ought to, and duty. It is also concerned with the ways people either individually or as a group decide what actions are right or wrong, right? If one ought to do something, if one has the right to do something, or if one has the duty to do something, right? So, and we know that, there's individual ethics, there is group ethics. And this is really just kind of a basic definition of what the ethic is. It is different from morals. Okay. So morals um, is basically dealing with right or wrong behavior, right? It's conduct, it's character. And so morals, we think of it, sometimes we use those words interchangeably, but they really are two different things. Um, so why is this all important? When we look at ethics, we all have our own right interpretation of what we think is right or wrong. It gives us our own little individualized guidelines on how we choose to live our life, right? Because we choose our own ethics. And of course we learn things as we grow, but things change, right? We get older, we have different points of view. Your yeah, so your personal code of ethics is going to influence your nursing ethics as well. And there are going to be times in your practice as a nurse that your personal ethics may conflict with the law. And then we think about nursing law, we think about your state nurse practice acts. So, what are some things that, what are some what's the word I'm looking for? Yeah, what are some things in healthcare or nursing that may like professional ethics that may conflict with someone's personal ethics? Anybody have any idea, any examples where there may be a conflict?
Would like religion be one? Would that
Okay,
be?
religion can be one, right? Absolutely. What else?
Sexual preference,
Sexual preference. Okay. So we have religion, we have sexual preference. What else?
race, age.
Race, age, all of those are awesome. Yep.
Mm,
So I'll propose one for you. Okay. So let's say you're working in the emergency room. Okay. And I'm just going to use an excerpt from society because unfortunately this has become something very common. Let's say you're working in the emergency room and the ambulance is bringing in a person who just committed a mass shooting and was injured in the process, and they're bringing them to your emergency room for treatment.
You
What
have
do
to
you
give
do?
it medical attention regardless.
Right? That is our job, right? We
mhm.
have to provide their medical attention. Okay, they're a human being just like anybody else, regardless of the act that they just committed. Okay. Um, but it could also be, um, think about um, another controversial topic would be abortion. Okay. And I know abortion laws have changed, but what if you had, what if you strongly, disagree with abortion and you have a client that comes in and they had a botched abortion and now they need emergency care to care for that, right? That could also, right, conflict with your personal ethics. With that being said, we don't get to choose the patients that we care for, right? They kind of choose us, really, right? Wherever we are working. And as human beings, as nurses, and nurses that take an oath to care for other client or for care for others, right? We need to be able to provide quality, safe, effective care for whoever walks through those doors. In it, you know, it's hard, especially like I said, if you had a client that, just went out and killed a whole bunch of people or injured a whole bunch of people, and now you're here trying to save their life, right? It may be taking care away from another one of those victims, but they are a victim just like the other ones are. And so those are just some examples, right, of where your personal ethics may interfere with your professional ethics. Um, you know, if there's a true concern, a true issue, I mean, you could always try discussing it with, your supervisor or another nurse to see if there's an assignment switch, but that's not always guaranteed, right? It's not guaranteed that somebody is going to switch assignments or switch patients with you. And making a really good, trying to think of a good word for it, doing a really good self-assessment, I guess would be effective or a good word. Really looking and diving down into how you feel about certain situations and kind of, you never know how you're going to react in a situation, right? Unless the situation presents itself. But you can have an understanding about your belief system. And we just as individuals, we all have different beliefs, we all have different morals and values and opinions and all of those wonderful things. And I think that's what one of the things that makes us a great society. We're not all going to get along. I think if everybody got along, it'd be really boring. But understanding how you feel about certain situations and trying to put those feelings aside when you're caring for your clients because they're the vulnerable ones, right? They're the ones that need us to be everything that we can be. So we look at individual autonomy or individual rights. Um, all of your healthcare entities, especially hospitals, even long-term care setting, like environments, they have ethics committees. And it's usually a group of people or, group of providers, that can help with, making difficult ethical decisions, regarding care. So this, is kind of, something that is always around. Um, and with that being said, we have to make sure that we are not infringing on other people's rights, regardless of what their beliefs are, what we believe is right for them versus what they believe is right for themselves. So when we look at providing care for clients, the rights of the individuals that we are caring for often they're gonna take precedence over pretty much everything, right? So all individual autonomy means self-rule, right? People have the capacity to think, and then based on their thoughts, they can make the decisions freely, right? Whether it's to seek care, healthcare or not, right? Like if you have the flu, or you have pneumonia, you have a hurt foot or hurt arm, right? You make that decision whether or not you want to go to the doctor, right? Some of us will put it off until we can't take it anymore, or some people are as soon as something happens, like, I got to go to the doctor right away. Um, Everybody has the capacity to make that decision. We look at individual rights. That means the ability to assert one's right, sorry. And the extent to which somebody can exert their rights is restricted, right? Our rights are really restricted to a certain extent, right? We can't restrict the rights of other people, right? That is something that goes against ethics and morals, right? And so their rights can't restrict the rights of others. So, for example, the client's right to refuse treatment can be at odds with the healthcare provider's duty to always act in a way that will benefit the client, right? That's a huge thing. And we see that a lot in healthcare, right? The provider will recommend a treatment option or, and maybe the client's like, nope, not doing that. Or we'll recommend diet changes and exercise. And they'll be like, oh no, I'm not changing my diet, right? I'm not exercising, right? So that sometimes can, be a nice little conflict. But that's, their right. That's their right. They have the right to refuse care, to seek care. So again, they have the right to consent to care. They have the right to choose between alternative treatments, right? There's not always one option, may or maybe one best option, right? But there's usually alternates that we can offer. They have the right to consent or refuse, and women's rights over their own bodies. And we can talk about that. That's a whole separate conversation, right? So, ethical responsibility as nurses. So, tell me what it means to be an advocate. What does it mean to advocate for somebody?
Like speak up on their behalf.
Speak up on their behalf, right? You know, um, to make sure that everybody is doing the right thing for that person, right? We meet patients, clients on some of the best days of their lives, right? We may have new moms coming in, they're all excited having their first baby, right? Or we meet some people that are on some of their worst days of their lives. Doesn't matter if it's good or bad. Anybody that works into a healthcare setting is in a vulnerable state. And it is our job to help care for them, right? Because they still need information. They need to know what's going on. They need to be informed. They need education. They may be scared, right? Lots of different things, overwhelmed, overstimulated, right? So they're vulnerable and they need us to advocate for them. One of the best ways we can advocate for our clients is to tell them what's going on, right? Um, informing them this is what we're doing, this is the plan of care, and really helping them to understand what is going on. I don't know if has anybody ever stayed overnight in the hospital or a couple days in the hospital? It's a lot, right? You got people coming in all the time, right? I need blood. I need to check your vitals. It's time for your medicine, right? Um, they say you're supposed to get rest in the hospital, but here we are, we're waking you up all the time, so you don't really get a whole lot of rest. So, and then imagine being in the ICU and there's all sorts of alarms and IV pumps and ventilators and people and lights and noise. Um, so it can be overwhelming. It can be scary. So again, education, lots of knowledge. Tell them what's going on. Give them all the information that they can, can help them. Um, I, okay. Give me one second. Let me answer this. Um, okay. Um, so again, education, giving them all the information. Another thing is accountability. So what does it mean to be accountable?
Owning up to like what you did or
Take responsibility for your
Responsible for
actions.
actions and decisions.
Absolutely. You are answerable to yourself, to your clients, to your instructors, right? To your supervisor. And you're answerable, right? So, you are held to a certain level as you are out there, and you are accountable for all of those nursing actions that you perform. And so, how do we measure accountability? Accountability is measured by the nursing standards of practice. And we'll talk more about nursing standards of practice later on. But the nursing standards of practice is what a prudent nurse with your education and your experience would do in a similar situation. Another one is colleague reporting. And I feel like I'm a broken record when I say this, and I hope you never have to be in this situation. But this is an ethical responsibility we have as nurses. So if you have a peer, a supervisor, a subordinate, or any other member of the healthcare team, um, that is, acting odd or has behaviors that could put patients in harm's way. So if they come to work, drinking or drunk, if they're diverting clients' medications for their own use, if they're not monitoring their patients, if they're sleeping while they're on duty, if they're verbally or physically abusing clients, these need to be reported. You are required to report this. I was telling the class earlier, had a situation. I didn't have a situation, but I was reading about a situation where a client or there was a patient, a client that was being abused. Um, and the nurse was there was one nurse that was doing it, but another nurse had witnessed it, and the other nurse that witnessed it did not report the abuse. Okay. And in the process of the investigation, it came out that the other nurse knew about the situation and didn't report it, and she got in trouble as well. Okay, so sometimes we don't want to have to, what is it? We don't want to snitch. But when we're taking care of, our clients are our primary responsibility. So if that does occur, obviously you need to tell somebody. The other one is system-based issues. System-based issues, we have to be able to identify system-based issues to ensure that we are providing quality care, high quality care to our patients. So, and I always say night shift gets the short end of the stick on this. If there's a new procedure or there's new equipment that is being introduced for use, all right, do not use new equipment if you have not been trained on that equipment. In some cases, right, if oh, it looks easy, I can do it, and you use it and that equipment causes patient harm, that could be a real, truly negative situation. Um, and so, you don't ever use new equipment without getting the proper education or the proper training. If you're not getting the proper training, then you report that to your administration, okay, whether supervisor, I thought that's what happened. Let your supervisor know, your manager, um, administration, and say, I can't multitask today. But I always say when you're going to introduce a problem to somebody, come with the solution, right? It's easy. It's easy, right, to recognize where situations occur that, need to be fixed. But come with a solution. Say, hey, I think I have an idea, of how we can fix this. We need to have training on all shifts. How do we ensure that training is going to occur on all shifts? Just offer that type of, always be supportive. It's going to make you stand out, make you seem a little bit, more like you're really acting as part of a team, that you're looking out for not only yourselves and your teammates, but your patients as well. Other principles of ethics, and I know that everybody's heard of the ANA Code of Ethics. And so we look at our code of ethics. It's your non-maleficence, your beneficence, your autonomy, your fidelity, and your justice. So non-maleficence, right? Do no harm. That is always our first thing, right? We don't want to harm our patients in any way. So give me some examples of things that you've learned or things that you do to help prevent harm to your clients. What are some things that you do? And you might not even realize that's what you're doing. What are some
Like,
things? Go ahead.
like when one of the sample could be like when you give the call button for them to call you in case they need help, so they can fall from the bed.
Absolutely. Making sure they have their call light. Absolutely. That's one way we can help. What else?
Lower the bed before giving the care.
Okay. Lower the bed before you leave that room, right? Bed in the lowest
Mhm.
position. Good job. What else?
Checking orders.
Yep. Asking their name, make sure that's the right person, verifying before meds, checking your orders. Absolutely. All of those things, right? Your rights of medication administration, your 6 checks, you're lowering the bed, you're giving them their call bell. Um, what else? Another thing, and we may not even think about, we don't, oh, I don't know about you, but I don't try to do this anyway, but making sure that we're not performing any unnecessary tests and procedures, right? Not using our patients as test dummies, right? Only performing what is medically necessary. Um, and then always protecting those who can't protect themselves. And this is something that's, think about your your weak, your older adults with dementia, your cognitive impaired adults, children, right? Making sure that we are protecting them because they're even more vulnerable, right, than some of the normal adults that, some of the other adults that we may be taking care of. So really good job. Um, Beneficence means to do good, right? And so this is the basis of trust in nursing, right? And it's very similar. It sounds, some of it sounds very similar to your non-maleficence, right? But it's really preventing harm and removing harm and making sure that we are not causing harm. And so some of the things that some of the things here would be, let's see, um, making sure that you provide a shift handoff report before you leave, right? You sit down and you perform that change of shift report, right? A lot of people like to use SBAR, and that's a great way to do change of shift. If you do make a mistake or if you give the wrong medication, it's reporting that as soon as we know what happens. It's monitoring our patients, right? To monitor for any adverse effects. It's trying to think of what else. Um, those are the ones that I can pretty much think of. Um, but it's, again, it's doing good for our patients. We talked a little bit about autonomy, right? And what autonomy was. It's the freedom to choose. And so it doesn't mean that people can just do whatever they want either, right? But it does mean that, like I was saying earlier, they can, think through all the facts of what is going on. Then they can decide to, on the basis of their own thinking process, what actions they want to do, right? And that's their personal opinion or their personal option. It is not influenced by anybody else. They make their they make their autonomous decision. With that, okay, we also have privacy and HIPAA is a little bit different. And we'll talk more about HIPAA later, but privacy is a legal as well as an ethical issue. And I know it's like, why is it an ethical issue? Um, we know that even being autonomous, we have the right to privacy. And so this is even, um, and I think the book, well, I'm trying to remember because I don't know exactly what the book says, but it's like the instructor, if you're in clinicals, right, and, the person needs a procedure done, a nursing procedure done, we don't just walk in with a nursing student and say, hey, we're going to do this, right? We always ask, we always ask the patient, like, hey, I have a nursing student that would like to come in and perform this procedure, whatever it is, and, get that person's permission. And, it can be, frustrating. It's part of it on the student's part, right? Because, but I really want to go do it. And the client said no. And we get that, but we have to ask, right? Because that client has the right to know that a student is there. And they are the one that gets to, make the decision what can be done or what can't be done. Um, Fidelity means to be true. Okay. And so when we think of being true, it could be a combination of advocacy and beneficence and non-maleficence, kind of all rolled into one. But we always want to make sure that we are putting the needs of our clients above anything else. Things like and I don't know, I've had this happen. Um, but you overhear maybe a CNA or another nurse talking bad about clients, you know, um, and they're just mean, they're just nasty, they're this, they're that. Um, some clients can be challenging, not going to lie and say that they can't. But we don't talk bad about our clients. We don't discuss them in a negative way. Um, it just doesn't show good professionalism, good advocacy when we do that. Other things, not to talk about your clients in the hallway, right? In the cafeteria, um, you know, um, in the hallway, say the hallway, in the elevator, or even out in public, right? We don't talk about our patients when we're out with our friends at the mall, out to lunch. Um, I know it sounds crazy, so I guess that's probably the wrong word, but even though you're not using patients' names, behaviors, diagnoses, things like that can be recognized by somebody else. Like, you may be telling a story about behaviors, and, that person sitting next to you in the food court at the mall be like, oh man, that sounds just like my brother-in-law or my uncle or my dad. Okay. We just don't, it's just not appropriate. Um, and so making sure that we're protecting them. We're not, we're being true. We're not, violating their rights in any other way. And justice means being fair to all. And so, what you do for one, you should do for the other. Okay. And I'm not saying that everybody is going to get absolutely the same thing and that, but, we deal with our clients. We just want to make sure, again, that we're being fair. Okay. That, of course, there's going to be some clients that are going to be more sick than others that are going to require a little bit more, a little bit extra. That's not the same, but we don't want to deny anything. Anybody have any experience in long-term care? Anybody a CNA working in long-term care? All right. The best example I have is you have two females in a room. What happens if you pay a little bit extra attention to one of those females? What does the other one do?
Gotta
Start
find
complaining.
everything for
They
you to
get
do.
jealous.
Yep.
Oh my
They feed
gosh.
off of each other.
You don't like me. Why did you do that for her and you didn't do it for me? Oh my gosh. Right? Like it just never fails. And so, right. And you may not even have done anything that is above and beyond. You could have just been providing just basic care. But if you brushed one extra hair on her roommate's head and you didn't do it for her, that's it. It's the end of the world, right? Um, so again, it's just being fair to all, treating everybody with respect, being kind and considerate and empathetic, regardless of, what's going on. So this term, beneficent paternalism, and I know some of you already did exam reviews and you're like, oh, I remember this now. All right. So beneficent paternalism. The definition here is a disrespectful attitude towards the client and what the client has to contribute to personal care and recovery. It's an I know what's best for you attitude that discounts the client's knowledge of self. Okay. What does that mean? Okay. Um, this could be if, let's say, a client asks you, well, I don't know, maybe the doctor came in and gave them some options for treatment and they ask you, well, what would you do? And well, if I were you, this is what I would do. We don't do that. That's beneficent paternalism. Okay. We don't tell them what to do. We don't do that. Okay. What we could do is, well, I heard Dr. Jones, he told you that you could do this or this or this, right? And so, if you need a little bit more information about those, then maybe we can get him back in here, or, it's really up to you to make the decision, because only you know only you know what's going to be best for you. Okay. We don't go into those conversations. That's a whole rabbit hole loophole that you don't want to get drawn into. Okay. Other things is, another example of beneficent paternalism is writing the care plan without the client's input. Okay. Let's say you have a newly diagnosed diabetic patient and you're writing a whole care plan, and you're going to make all these diet changes and you don't have any input from your client, and you go back and you tell your client, this is what we're going to do. And your client looks at you and he goes, oh yeah, no, we're not. Right? I'm not going to make all those diet changes. But this is things we don't want to tell anybody what to do. Like this, it's almost like it's a disrespectful attitude. It's like, we talk to our kids, right? Like we know what's best for our kids, right? But we can't treat our clients like that. The only time, because there's always an exception to everything, right? The only time that this may be acceptable is in an extreme emergency situation. It is most often around a medical decision. So, usually with a child too. So, if the parents are refusing to sign consent for a life-saving treatment, then the provider can petition the court and get an order to provide that treatment. So I guess the best one I could come up with, and I said this earlier, what if we have a Jehovah Witness child, a Jehovah's Witness child, okay? We know Jehovah Witnesses don't accept blood products, right? Let's say we have a Jehovah Witness child that was involved in an accident and absolutely needs blood products, okay? Life-saving, no other options available. Parents aren't going to sign consent, right? Because it goes against their religion. The provider can petition the court for permission to give that blood transfusion. Okay. That is the only time that this is ever really justified, is when we need to provide a life-saving treatment to a child. All right. So let's go into this wonderful Nurse Practice Act. So who here has gone on to their state board of nursing or has gone and looked at their state Nurse Practice Act? Anybody? Nobody. Okay. So your state Nurse Practice Act. Okay. If you haven't done it, I highly suggest you go and you look at your state Nurse Practice Act. Okay. So the State Nurse Practice Act defines your nursing practice. It establishes the standards for nurses in your state. Okay. So it's going to tell you what you can and what you can't do in your state. And that's really important to understand, because you don't want to go and spend all this time and effort in nursing school and then get out into practice and do something that could potentially risk your license. Okay, so again, my suggestion is you go and you look at your state Nurse Practice Act. Ignorance of your state Nurse Practice Act is not a defense against legal proceedings. 100%. You can't say, oh, I didn't know. That's not going to work. You are responsible to know what your state Nurse Practice Act says as far as what you can and cannot do in practice. Now we have the compact states, right? The nursing compact states. And if the state is a member of the nurse compact, then you can work from one state to the next, right? So if let's say you live in Florida and you decide that you want to work in Georgia because it's closer to you for you to work in Georgia or Alabama, or if you live in Ohio and you're closer to, I don't know what's on the Illinois on the other side of Ohio, right? Or even if you work in, if you want to work in Pennsylvania because you're closer to Pennsylvania, whatever it is, West Virginia, I don't know. Okay. If it is a compact state, yes, you can work in that state. However, you still need to know what the Nurse Practice Act says. Now, with that being said, they are very similar in most of our compact states. So that is something that makes it a little bit easier when we're looking, to cross state lines. But please never, when you get your license, hopefully before you get your license, go and look at your Nurse Practice Act. So with that, some of the content of the Nurse Practice Act, again, it's the rules and regulations, okay, for each state. So it will, the general provisions of the Nurse Practice Act, it's going to outline the functions of the state boards of nursing. It is also going to outline the general procedures, the fees, that kind of thing, the licensure process, what would constitute unprofessional conduct, also information related to suspend or to reasons for suspended or revoked licenses. It also will outline the impaired professional program, some of the responsibilities of the Nurse Practice Act. It outlines the general functions of the nurse. So some states have one Nurse Practice Act that will outline the practice, outline practical nursing and, registered nursing all in the same. Some states have two, where they'll have one for LPN, LVN, and then one for RN. Just depends. It also defines nursing. So it'll define the LPN, LVN role. It'll define the registered nursing role. And it also outlines the standards for conduct. All right. Again, really important to read the Nurse Practice Act. It also will tell you about nurse continuing education. And I'll talk a little bit more about continuing education in about 2 seconds. So then we have our state boards of nursing. All right. Everybody's heard of the State Board of Nursing. So again, there could be a single Nurse Practice Act or there can be two separate Nurse Practice Acts, depends. Okay. Then of course the boards also have committees or councils that fall under them. So it's pretty interesting. And again, even though the Nurse Practice Acts are very similar across those compact states, there may be some differences. Okay, so what's legal in one state may not be legal in another state. So that's why I said it's always really, really important to make sure you look at it. So other comment are board of nursing functions, licensing and certifying, right? We know once you graduate, right, as you're getting ready to, go take that wonderful NCLEX, first thing you have to do is apply for a license, right? So you're going to have to go to your state board of nursing and you have to apply for a license. They're the ones that set that up. They set the fees. So how much does it cost for you to get your initial license? And then how much is it going to cost every time you need to renew? It also establishes the standards for educational programs. So colleges like Fortis or community colleges or universities within the state, okay, they have to meet the standards that are outlined by the state's board of nursing. Okay, they're the ones that tell us what they're not like, you have to have this course, this course, this course. But they do say, they give us what we need to cover within the nursing program. One of the biggest, and they also approve schools of nursing. Okay. So not everybody, like I can't just wake up tomorrow and say, I'm going to start a nursing school and go run out a building and just start enrolling students. Okay. There is an approval process for
Hold on,
nursing.
Wedge. I can't hear you.
I'm sorry.
I'm sorry. I was off.
Oh, forgot what I was going to say. Oh, it just left my brain. Oh, one of the biggest questions that I used to get from nursing students. why do we have to do so many clinical hours? Because your board of nursing said so. It's always, and that is one thing they do outline. You have to have a minimum amount of like nurse of clinical contact hours in order to graduate from nursing programs. So that is kind of how we set up our programs. They also determine duration and the renewal of licenses. Okay, so um like, is it every year, every 2 years that you need to renew your license? And then some boards require continuing education credits for renewal of license. Very important to pay attention to that too. So when you get, your most states is I think about 2 years for renewal. Check your nurse practice act, check your board of nursing to see if your board of nursing requires any continuing education credits. Because these are things that have to be done throughout the year. It's not like, oh my gosh, my license expires next month. I need to renew. Let me get all my continuing education hours done now. It doesn't work that way. If you get audited, they're going to go back the last 2 years to see when you completed those CEs. Just food for thought. Keep that in the back of your mind. A lot of your organ, depending on where you're working, um, there's only one place that I worked. Most of like the training and the modules that you do are in services. In services are not continuing education. Like some places will offer continuing education as well. Like one place I used what is it called? Relias. And sometimes with Relias, there will be some CEs that are available to you through your organization. But so a lot of times you're going to have to find CEs. Just be mindful of that. Carrying out disciplinary action for violators. They also develop the programs for the impaired nurses. So if you have like a drug or an alcohol problem, you get caught diverting medications, that kind of thing. The board of nursing actually sets up the program. And it is a very detailed program. And I heard it's very expensive, because it does cost out of pocket for you to go through these programs. However, it is one of the ways that the board of nursing, the states have to, kind of set up for some of our impaired nurses who want to get help. They want to go into recovery. They don't want to lose their license. Their license will be suspended, especially if they're caught, drinking at work or drunk at work or diverting medications. But this is a way for them to potentially be able to get their license back. Okay, so those are those impaired programs, impaired nursing programs. They also, suspend, revoke licenses. They also deal with the appeals processes. So some things that would be considered unprofessional, oh my gosh, some things that would be considered unprofessional conduct, negligence. And so the negligence is when the nurse doesn't do what a reasonable, prudent nurse would do in a similar situation. Okay, so there is some risk to health, safety, or physical or mental health of a client. Violation of the Nurse Practice Act. Some state nurse practice acts will list specific violations. So like becoming personally involved with a client. I know Texas does. Texas actually has that in their Nurse Practice Act. Because I just was doing my CEUs for renewal. And I was like, okay, so I had to go through, and part of the, CEUs for Texas is you have to review the Nurse Practice Act. And so that is specifically in there. And I was watching, I was something, I don't know where I saw it. But it's been pretty recent that a nurse recently had their license suspended because they became physically and personally involved with an inmate at the prison that they worked at. So I'm like, okay, I mean, probably not the best. But yeah, so just be mindful. Incompetence. Examples are a failure to meet generally accepted standards of nursing practice, negligence, or a nurse's mental disability that would interfere with client safety. Okay. So be very careful. This can include client injury, and that injury can be physical, it could be emotional, it could be spiritual. And so when we talk about mental disabilities, usually when we think of mental disabilities, I always think of the more severe mental disabilities. And a lot of times, with some of those severe mental disabilities, right, they turn to illicit drugs and alcohol, right, as a way to help manage the symptoms. If they, were, the severe mental disabilities, if they're a danger to themselves or others, those types of mental illnesses. Unethical conduct. So unethical conduct, breach of nurse client confidentiality, refusal to provide care for someone because of race, creed, color, national origin, disease, or sexual orientation. And then violation of the ethical code for LPNs and failure to maintain nursing competence. And this goes back to what I said earlier about like new policies, new procedures, new equipment. If you've not been trained on new equipment, don't use that new equipment until you have been trained. Okay. Um, I had I had a client, a patient who he was alert and oriented. I didn't ask all the questions that I wanted to ask because I wasn't really something that I needed to know. He volunteered the information, so I wasn't gonna like, oh yeah, tell me more. I want to know all about it. Um, but he had been in a facility, and I don't know if they I don't know the ins and outs or whatever. But they were transferring him. They were using a Hoyer lift and they dropped him on the floor, and they broke his hip. And um and I did ask one. I'm like, was it one person or two people? Because just being nosy. He was like, oh, it was only one. So we already know right then and there, if you're using a Hoyer lift, right, you need at least two. So we want to make sure that we're providing for safe care, and making sure and how to use equipment is really important. That was just an example. IV pumps, some of those IV pumps can be really confusing. Okay. I remember when they first came, I feel really dumb, but when they first came out with the kangaroo pumps, the tube feeding pumps, where you can hook the tube feeding and the flush together, and it'll flush it like like however you program. So usually we do like every 4 hours. I could not figure it out to save my life. I couldn't figure out how to set up the dumb pump. I felt so dumb, and I was like, and then so obviously I was like, well, I can't do this. And so I had gone to get some help. And when I watched the other nurse do it, it just made me even feel worse because it was like such a simple thing to do. And I was just like, oh, I'm getting old. But again, don't use any equipment if you don't know how to use it. And then alcohol or drug use, talked about this. And I'm going to say something else about this, and I'll say this first though, but alcohol or other drugs abused by a nurse. So diversion of drugs, especially your controlled substances as a threat to client safety. For one, you may be diverting and selling the medication, but that means that your client isn't getting the medication. So now their pain may not be controlled. Okay. And they're not getting their medications. They're being billed for those medications that you're supposedly giving. So be mindful of that. I also was listening to a podcast, and I thought that this was an interesting just tidbit of information. So, that I don't know how many states because I don't keep track of it, but in a lot of states, marijuana is legal, right? So, you can buy and smoke and buy gummies and all of those things, right? I was listening to a podcast where, and I don't remember what state it was. I don't know if it was state specific or not, but there are certain organizations, certain hospitals and healthcare systems that even if you have a medical marijuana card and you pop positive, they will not hire you. So be mindful of that. When when marijuana first became legal, I have one of my daughters is she's an occupational health nurse. And so I asked her, I said, okay, what do you guys do if, right? And so some organizations don't even test for marijuana. I don't know if more of them are starting to or not. Um, but she was saying that if they had a medical marijuana card, they just couldn't use within 6 hours of their shift, right? Because you can't go to work impaired, whether you have, a medical use for it or not. Um, so I just thought that that was interesting. So, everybody pushed for it to be legalized, but now, we have to be really careful. Um, to answer your question, Oceana, that's usually as long as you have a prescription, um, and that you present that to the provider at the time, that's usually not an issue. I've never seen that be an issue because there's adults with ADHD that have um, amphetamines in their system, right? As long as there's an active prescription and that you can show your prescription, those are usually fine. I just thought it was interesting, with the push. Um, so just, I mean, not suggesting anything or anything like that. I was just providing information. I just thought that was interesting because a lot of people use it, right, for recreational purposes. And so just know that there, could potentially be some conflict there. And I didn't finish reading or listening to the podcast yet. I listened to it, but I wasn't really paying a whole lot of attention to it. So I'm going to go back and listen to it and see if I can delve out or get some more information from it. Because I thought it was just interesting. All right. So before we go any further, you guys ready for a break? Ready for a break? I've had way too much coffee today. I definitely need a break. All right. Let's be back at 6:40. All right. All right. So disciplinary responsibility of the board and unprofessional conduct. Um, so, what could happen or, what are the responsibilities of the board? So they could what's the word I'm looking the word I'm looking for? They could make you pay a fine or a civil penalty. They can refer to an alternative to discipline program for practice monitoring and recovery support. So that's like your impaired nurse program. So that would be a potential. You have to, one of the big things with that is you have to make sure you comply with all aspects of the monitoring program. They can do a public reprimand or censure for minor violation of Nurse Practice Act with no restriction on the license. They can also impose requirements for monitoring, remediation, education, or other provision tailored to the particular situation. So, like I've seen a couple, I was a new nurse. I don't remember all the particulars. I just remember it was a new nurse um, who um, was working in long-term care um, and completely overwhelmed, which if anybody has spent any time in long-term care, it is a possible situation that can occur. And patients really, they just weren't receiving the medications that they were supposed to be getting. And she got caught. And so instead of, suspending or revoking her license, they made her do some education regarding safe medication administration. Also, I think part of it too was like stress management, um, and other things too to just, she knew what she did was wrong. She was overwhelmed, didn't get all the training that she probably needed as a new nurse going into the facility. So they gave her some education. Um, also had one, I was sharing this earlier. Um, one of the facilities I worked at a while back, they had a nurse who had called out sick and falsified a doctor's note. Okay. How the facility figured out that it was a false document, I don't know. But they found out that it was falsified and they reported that nurse to the board of nursing. And so the nurse had to do some education about ethical practice and things like that. So it's not always that they're going to go in and they're going to take your license. Okay. There are things that they do try to work with some people to, so they don't have to pull their license. They can also limit or restrict one or more aspects of practice. Um, so they can do probation with certain restrictions, limit the role, the setting, the activities. They can limit hours worked as well. Like we're going to say you can't work full time, can't work more than 20 hours a week, that kind of thing. I've also seen where they've restricted nurses from passing narcotics. Okay, so they can't pull, they can't pass narcotics. So just it's again, some of these disciplinary actions are going to be related to what the situation was. And then, of course, there's always the chance that they can either suspend your license or revoke your license, depending, or even the nurses can voluntarily surrender their license. I've seen that happen as well. Um, actually, I know somebody that I had gone to school with who um, developed an addiction after an accident and um rather than admitting to having a problem and going through the monitoring program, she just voluntarily surrendered her license. So she had no intentions of going back into nursing. They also can do remediation. So again, extra, educational content. And then, there's always that other, depending on what the actual issue is. So if somebody is getting reported to the board of nursing, so here's an example. So a nurse is reported for stealing a client's narcotics to the state board of nursing. All right. So after receiving the complaint, okay, they are going to look at it. Is the nurse's behavior unsafe? Is it incompetent? Is it unethical? Of course, is that chemical affecting the nurse's judgment, making them unsafe to practice. And also, they're going to confirm that the stolen narcotics are a violation of the Nurse Practice Act as well as the law. And that is when the board will review the complaint. Okay, so they're going to look to see if it's a violation of the law of the Nurse Practice Act before they review the complaint. And then after they determine that it is a violation, then they're going to do their investigation. So they're going to verify what state the nurse's licensed in. They're going to do interviews. They're going to gather their evidence, and then they're going to notify the nurse. Okay. Um, and then the nurse will then go in front of the board. Okay. So during the board proceedings, that is when the nurse can respond to the allegations against them. And then the board action will follow the board proceedings, and that is where they determine what the disciplinary action is. And there's a variety of things, like I said, depending on the situation. They can do emergency action, so they can do immediate suspensions to protect the public. Again, disciplinary action, remediation. And then they report it. Okay, so that's the last part of it. Once everything is said and done, they will do the reporting and the enforcement. So NURSYS, NURSYS, is a national database for verifying license, discipline, and action privileges for nurses. Okay. And on this site, it contains the nurse's license number, the expiration date, and any violations against that nurse's license. Okay. So, again, especially with the compact states, nurses can work across various states. So, this is a way national that employers, even other state boards of nursing, whatever, can look at to see if there is any issues with that nurse's license. The National Practitioner Database, federal law requires that any adverse actions, disciplinary actions that are taken against a healthcare professional's license be reported to the National Practitioner Database. So this information is available. Your nursing license, is a matter of public record. So anybody can, go either to nurses, or the State Board of Nursing to look up your license. Has anybody ever looked up a license before? No. I'm going to stop sharing for just a second, and I'm going to show you. I'll show you what it looks like. And I'm going to use my nursing license. So let's see. Oops. I'll share my screen again. So this is what the NurseList website looks like. Okay. Actually, when you first get to it, I'll start over. Oops. Come on, cooperate. There we go. Where'd it go? So here, when you first get to the website, this is what it looks like. And so I'm just going to do quick confirm so I can hit click or click on that. I know my license number. I will say that I am not a robot only because you'd just be amazed how many Jennifer Martinez's there are in the state of Texas. So if you put my name in, it'll take you a while to find it. So I'll hit search. Okay. And here is all my license information. Okay, so my practical nursing license from Virginia is up here. My RN license from Virginia is up here. This one right here with the little T number. So when I first moved to Texas, they give you a temporary license until like all of your background check and all of that stuff is done. And then my actual license number. So it has my name, my license type, the state, and then my license number. And if I were to click on view report, I'm not going to download because I have it. Um, it will also tell you if it is active. Unencumbered means that I don't have anything on my license. It gives my original date of my license, my expiration date, and I have the compact status. Now, if there was something on my license, then this right here, let's see, these are all expired, but right here, it would have something that says, I forget, I don't know exactly what it says because I've never, but it won't say unencumbered. Unencumbered is good, okay? But so that's all the information that you're going to see when you get to nurses. If you need, if the employer wants to, if they need more, they can always download the report and keep it in your file for, whatever reason if they need to do that. But that's what nurses looks like. And so again, our nursing license or public record, so we could, so it just, my gosh, what is the word I'm looking for? So anybody can look it up. The difference with the, I don't think it will, I'm going to try. I don't know if it will or not. Let's see. I'm going to try something. I don't know if it'll show you or not, but we're going to see. No, it doesn't. I was going to see if it pulled up my old Virginia license, but it does not. Let's see. Let's see if I push expired. Nope. Doesn't even have my expired license up there. It's interesting. Let me try a different way. I was just going to try to show you the difference between board of nursing website and nurses. Oh, interesting. Okay, I'm going to share my screen again. So this is the difference. So this is Virginia Board of Nursing. Okay, so this is the Virginia Board of Nursing website. So here's my LPN. You see my address was updated. So when I transferred my license, Virginia Board of Nursing updated it. But if I were to click on it, okay, it's got my license number. It's got just my city and my state, my initial license date, when my expired. It's compact. And again, additional public information. If there was anything on my license right here, it would say yes. Okay. So, and then would be a hyperlink. Okay. So if it said yes, you would be able to click on it. It would be a hyperlink. And then, and a potential employer, whoever would be able to see the full report from the board of nursing as to why there is something on on that person's a license. So it's a little bit different. Primarily it's going to still show, very similar information. And so again, the State Board of Nursing, that provides public information about nurses who have current licensure. Again, I showed you, it does, with some we'll have, the expired licenses up there as well, but I had to hit expired licenses in order to find my name. Um, so it helps potential employers to use the database to confirm your license number, your and expiration date, and of course any board action. So sometimes the information, anybody in Florida in this class? Is anybody in Florida? Okay. So in Florida Board of Nursing, they actually put your physical address on your address on your nursing license. So if, I wanted to, I could look up your nursing license and I can get your address. But you can see like it depends on the state, it depends on the Board of Nursing because Virginia just puts your city in your state. Um, so I learned that from a student. Um, we were talking about one day and they're like, no, Florida, they put our whole address on there. I was like, oh, interesting. But again, your nursing license is public record, right? So they do have access to that information. Other things to think about, talked about the compact states. Okay, so it is those interstate endorsements. It is great, it does make it a little bit easier. Most states do have a provision that if you are going to change your state of residency, you have like, I think it's 6 months, 60 days or 6 months, something along those lines to change your nursing license. But it is one thing that's really nice about the compact license, right? Especially for travel nursing and things like that. Or if you live on the border of a state, right? And like I was saying, if you live in Ohio, you want to work in Pennsylvania or Illinois or, West Virginia, right? If they're a compact state, makes it a lot easier. Like I know a lot of nurses when I lived in Virginia, some of them lived in North Carolina, but worked in Virginia. So it did make it a little bit easier. Um, One of the big things is that was a big concern was um, you know, the UAPs, okay? When we look at, nursing licensure, we are responsible for the care that our UAPs provide to our clients. So providing, right, that additional supervision. There's something else I wanted to say about the nursing compact. Um, oh, with the nursing compact, like I said, still, if you're going to cross state lines, you still need to look at the Nurse Practice Act, even though it's going to be very similar, in most cases, you just never know. So you want to make sure that you're always looking at that nurse compact. Now, if you want to move, like I changed my state of residency from Virginia to Texas. There's a reciprocity with your nursing license. So, of course, if you have your nursing license and you're moving from state to state, you don't have to take your NCLEX again, right? That's a national exam. Um, but there may be some um additional requirements that must be done. So for me to transfer my license from Virginia to Texas, you will have to go and get your fingerprints. You'll have to do your background check. And then that's why I had the temporary ID, right? Because I applied for the license and then I had to go through all those steps. I had to do what's called a jurisprudence exam, which I'm not gonna lie, that was hard and it was open book and it was still hard. And I had to do a human trafficking module. Apparently, in a lot of states, but really down here, human trafficking is a big issue. I know for New York, there's like some child abuse modules that you have to do in order to transfer your license. So if you're going to move and you're going to change your state of residency, look at your board of nursing and see what the requirements are. So that is something that, if you're going to change your residency. If you're not changing residency and you're just practicing across state lines, as long as they're a compact state, then, you should be good and you're following your Nurse Practice Act. All right, so we talked about nursing standard of care a little bit earlier. Again, that's your guidelines for good nursing care. You're held responsible for the nursing care. It has legal implications. All right, it is based on what an ordinary, prudent nurse with similar education and nursing experience would do in similar circumstances. So, how do how do you find out about what the nursing standard of care is? Okay. So here are some things. The Nurse Practice Act. I don't know how many times have I said Nurse Practice Act? in the last like hour and a half. I feel like I've said it a lot. Um, that identifies the minimum level of competency necessary for you to function as a LPN, LVN, or RN in whatever state you are working in. Okay, that's the minimal level of competency. The NCLEX, which is your National Council licensing exam, right? That also is a test of minimal competence. Okay, so minimum competence in order for you to practice as a safe nurse. Your nursing program. Okay, so based on guidelines, right, from the Board of Nursing, right? These nursing programs, doesn't matter what it is, a community college, a Fortis, university, whatever it is, programs guarantee a minimum knowledge base and the clinical practice necessary for you to provide safe nursing care. Okay, so your textbooks, the curriculum that is set up, your instructors, right? Even some of the nurses out at your clinical sites are excellent resources for information about standard of care. The written policies and procedures, okay? So when you start to work, the written policy and procedures from the healthcare agency that you work is also going to tell you what the standard of nursing care that must be followed at that facility. There's also laws. All right. So, you know, um, previous cases that had been brought before a judge and jury or just a judge. Okay. There's also laws that are potentially resources for standards of care. Um, Professional organizations like NAPNES, and your NALPN. And I don't know, do you know that you can go to your board of nursing and you can see why people have had their licenses suspended, revoked, limited? Did you know that you could do that? So you can go to your respective boards of nursing, whichever, Florida Board of Nursing, wherever you guys are. You can go to your board of nursing and you can look at case decisions. Now, Texas is really different. This is the first state well, I only practice in two states, but we get like a quarterly newsletter and it lists all the nurses that have had actions taken against them. It doesn't tell you why, it just lists them. But you can go to your board of nursing website, and I used to use this when I was teaching as well. And you can look to see why people have lost their license or had their license suspended, revoked, or all of that. And you can read the individual reports. Um, right now, what I've noticed in some states, there's a lot of nurses. You guys heard about the school in Florida, right? Where they produced a whole bunch of nurses that never went to nursing school. You guys heard about that, right? Um, they're still seeing a lot of downfall from that. So there's a lot of nurses getting their license revoked that I've noticed as a result of that. So it's, sometimes you have to fish through to kind of see what's going on, but you can see why what's going on as far as, why not students, but why nurses are not, they're getting reprimanded, they're having to provide education, that kind of thing. So how does law affect us? I know I talked a lot about the Nurse Practice Act and really, can't drill that in important enough. But we also have, criminal and civil law that potentially could affect our practice as well. So criminal law is a relationship between individuals and the government, or the government versus individuals. And so this includes things like felonies or misdemeanors. Misdemeanors a less serious charge, right? They can get a fine or prison sentence, generally less than generally less than a year. And it also can be reported to the Board of Nursing as well. So, you may see, and I've seen this too, where, health, either CNAs, nurses have stolen money from clients and have gotten caught. So that is something that is reportable as well. And then a felony, that usually they have a penalty that's, more than 1 year in prison up to death. And so this could be, homicide, larceny, embezzlement, whatever. This would be anybody watch The Good Nurse? Anybody see The Good Nurse, the movie, what is it? Was it a series? I don't remember. Or just a movie. Um, so, if you inject a client with a lethal dose of a medication and you kill them, right, that would be a felony. Is it a movie? I couldn't remember if it was like a mini series or if it was a movie. I read the book.
The series.
Yeah, okay. I did. I read the book. I mean, I actually know a nurse that worked with him. So it's really interesting. But anyway, um, another thing that I want to tell you with that Nurse Practice Act is things that you do outside of work can affect your nursing license. Okay, so be mindful of that too. Um, Shoplifting, DUIs, embezzlement, all of those, if they find out that you are a nurse or, it can be reported to the Board of Nursing, and the Board of Nursing can also take disciplinary action. So you are held to a higher standard, even if you were off duty. Civil is usually individual to individual. Okay. So, and it's some infringement on another individual's rights. And so it usually will result in a monetary compensation. And so, think about this. If, um, I don't know, let's say a patient fell and broke their hip. Because there was water on the floor that wasn't cleaned up appropriately. Okay, they can sue for damages, right? And that's usually going to result in compensation, and it's because of the loss of income, the pain, the suffering, right, as a result. Under this is your intentional and unintentional torts. Okay, so intentional means I meant to do it, right? I purposely sought out something to harm somebody, okay? Or it could be a threat, okay? Um, I'm going to put you in restraints if you don't settle down, right? That's a threat. You're not actually doing any, you haven't done anything, but that is a threat, right? And that's intentional. Like you meant to say what you said. It's not a joke. Or it could be actual physical harm, like you literally hurt your client. An unintentional tort, you didn't mean to do it, but it resulted in injury to the client. Okay, so this could be something like you gave someone the wrong medication. Okay. Hopefully nobody, most of the time we don't intentionally try to give somebody the wrong medication, right? So that's unintentional. Didn't mean to give the medication. I was in a wrong medication. I was in a hurry. I didn't take time to, look, double check and verify the medication, and it caused that patient harm. Okay. So that's the difference. Intentional, you absolutely meant to do it. Okay. And then unintentional is you didn't mean to do it, but it happened anyway. Other types of intentional torts. Okay. Assault and battery. So a lot of people get assault and battery mixed up. Assault is I'm going to beat you up. Okay. I'm threatening you. I'm going to beat you up. Okay. Battery is the actual beating. Okay. So B for beating. So assault is a threat. I'm going to beat you up. Battery is the actual physical harm that it results. Okay. And like I said, I always used to get them mixed up, and I had to stop. Um, False imprisonment, use of restraints. Okay. So false imprisonment is keeping them against their will. And it can include the use of restraints or seclusion. Okay. And so you can't just restrain somebody because you want to. Um, and restraints can be either chemical or they can be physical restraints. So a chemical restraint would be like you have a client who won't go to sleep. They're wandering the halls, not really bothering anybody, but you just don't want them there. You want them in bed. So you're going to go give them a sleeping pill. Okay. That's a restraint, right? You're changing their behavior to meet your needs. The physical restraints, right? Those are, like wrist restraints and vest restraints or, anything that is going to prevent them from moving. Defamation is damaging somebody's reputation through false communication. And we can defame somebody in two different ways. We can do verbal or we can do written. Libel is written communication. So, posting something bad about somebody on Facebook or Instagram or whatever other social media are out there, okay? That would be written defamation, that would be libel, okay? Slander is verbal, okay? It could even include gossip, right? Oh, she doesn't know what she's doing, okay? So just, those two I get confused too. So libel is written, slander is verbal. And then, of course, there's physical and emotional abuse, which should never occur from a nurse to a patient. Um, Physical abuse is generally easier to identify versus emotional abuse, right? You can't really see the scars from emotional abuse as well. Our unintentional torts is your negligence, okay? So negligence is failure to use care as a reasonably prudent and careful person would do under similar circumstances. The term for professional negligence is malpractice. Okay. So it's really the same thing. Okay. It's just in professional nursing and healthcare world, we use the word malpractice. So here are some common sources of malpractice. Medication errors. Notice that's like one of the top ones. Working while impaired, failure to follow standards of care, lack of observation and timely reporting, not using medical devices appropriately or accurately. As I said, if you don't know how to use something, you've not been trained to use a device, do not use it until you have had appropriate training. Failure to communicate. This is a big one. Whether it's an adverse reaction, a abnormal lab, an abnormal x-ray, okay? Failure to communicate to a healthcare provider, your RN, is extremely dangerous. Sometimes it's better to over communicate, okay? Give them maybe more information than they need. Failure to properly supervise a client. So, leaving somebody in the shower, not paying attention to them, they slip and fall and they hurt themselves. Negligent delegation and supervision. We're going to talk about delegation and assignment. But we will delegate tasks to our CNAs, our patient care techs, our, PCAs, whatever they're called, wherever you are. It is still our responsibility if we delegate a duty to a unlicensed assisted personnel. It is still our responsibility that it is done and it is done correctly. Okay. And there are very specific parameters for delegation. Failure to act as a client advocate and failure to get informed consent. You cannot perform an invasive procedure without getting informed consent signed. No ifs, no ands, or buts. Okay, you have to have informed consent signed. Anybody have malpractice insurance? So, why do you need malpractice insurance? There's a list here. Okay, lots of reasons. So, we know that we live in a very litigious society. Okay, we are starting to see more nurses, okay, that are being involved in court cases. So, why you should have your own malpractice insurance, okay? The jury's award could exceed the limits of your agency's coverage. So yes, your agency where you work, they're going to have a certain amount of coverage for you. But what if they only have $50,000 coverage for you and the jury awards $100,000? Where do you think that other $50,000 is going to come from? They're going to come from the agency. Guess who's going to be responsible for that other $50,000? Okay. Your employer, okay, may pay out an award to a client and then turn around and sue you for that award money. Or If you acted outside the scope of employment, okay, the agency can argue that they're not liable, so they're going to come after the nurse. Your employer's policy only covers while you are employed at that institution. So let's say there's a statute of limitations for things, which means, excuse me, that if something happens today, let's say that patient may have like 7, 8, 10 years to actually file a lawsuit. Okay, you don't have to do it right away. Because they may have to wait to see if there was going to be any long-term effects of what happened. Well, you're working there now, but let's say you leave hospital A and you go work for hospital B and you're doing fine. And here up comes this lawsuit from hospital A. Well, you don't work for hospital A anymore. So they're not going to be covered under their malpractice insurance. Hospital B isn't going to cover you because it didn't happen at their hospital. Okay, so you're stuck in the middle. You don't have any coverage. So you want to make sure that you're covered. And so other things too, even after a settlement, insurers can come back after the nurse. It's always really good. You want to try just to protect yourself as much as possible. I will tell you the nursing associations, they usually will have discounted rates for students as well as new nurses, like within the first year of practice. It's not horribly expensive, but it is something you may want to think about. And not every case that goes to a lawyer is going to end up in court. Okay. So, in order for somebody to prove that the nurse has been negligent, there's 4 elements: there's duty, there's breach of duty, there's damages, and there's proximate cause. All right. So, what does that mean? Duty means that you had a responsibility to care for that client. Plain and simple. You had a duty based on your education as well as policy, standards of care, all of that, and you were in charge of that patient's care. Breach of duty, okay, means that you did not, that the nurse did not adhere to the standard of care. And so either we had an act of omission or an act of commission. An act of omission means you did not do something, okay? An act of commission means you did something, but you did it incorrectly. Okay. And that what you did or what you didn't do injured that client somehow. And that's the damages. All right. So it is on the client or the plaintiff to show that the nurse's negligent behavior injured him in some way. Okay, they have to prove the damage. And proximate cause means there's a reasonable cause and effect relationship between either the act of omission, the act of commission, and the harm to the client. Did what the nurse do or didn't do actually cause the injury in question? Okay, so for example, an act of omission, okay? You didn't give the patient their scheduled dose of heparin, okay? And the patient had a blood clot, had a stroke, okay? And now he has the ramifications of that stroke, okay? They have to go back and prove that you missing that dose of heparin is what caused that clot to form and then the subsequent stroke, okay? That would be an act of omission because you did not give that medication. An act of commission would be if you gave somebody the wrong medication. Let's say you forgot to check their allergies and you gave them a medication that caused them to have an allergic reaction, which then potentially caused them to go and be intubated or, intubated and mechanically ventilated, whatever. Okay. So that would be an act of commission. Regardless, okay, if somebody is going to bring legal action, obviously the client's going to go find a lawyer. And we all know, we see the commercials on TV, you see the billboards on the side of the road, there's ambulance chasers everywhere, right? Client's going to go to a lawyer. They're going to tell the lawyer, hey, this is what happened to me. The lawyer is going to get all the medical records. And before it goes any further, he is going to have a nurse expert review that chart. Okay. So a nurse expert is somebody that is gone through additional training, okay, to be a legal nurse, I can't even say it, a legal nurse consultant, okay, and that nurse is going to review that chart to see if there's been any deviation from standard of care. If there's been no deviation from standard of care, then it's not going any further. It's going to stop right there because they don't have any basis for a lawsuit. If there was a deviation in if there was a deviation in standard of care, then that is when they are going to file the complaint, okay, and they will then serve the defendant, okay, and then that's when all your pretrial stuff happens, right? They'll do statements, they'll get witnesses, they'll have the nurse experts, they have the client, right? All these people, they're gathering all this information. They're also going to look at your policy and procedures from where you work. And then they will go to trial. And then during the trial, everybody is going to present their case. And then, whether it's a judge, whether it's a jury, they are going to make their decision. Okay. But remember, the plaintiff, the client, is the one that has the burden of proof. They have to prove that what you did or what you didn't do directly resulted in harm to them. And then generally, like I said earlier, it is some sort of a monetary penalty. And of course, there is always the opportunity for appeals, things like that. All right, I'm gonna delete that real quick. All right, so the nurse is caring for a client miscalculated the dose of medication and administered it to the client, who was successfully resuscitated. Is that intentional or unintentional tort? If I miss
Unintentional.
unintentional, is that negligence?
Yes.
Yes.
Very good. Absolutely. Oops. Didn't want that. That was my recording. Lord, there we go. Yes. So the nurse has committed an unintentional tort. Okay. They miscalculated the dose. They did not intend to do that. But they also did not maintain standard of nursing care, right? So very good. Good job. When we look at privacy and confidentiality. So we always talk about privacy. Maintain your patient's privacy, right? Don't share any information. So there are going to be times when we have to share information. All right. I mean, and so some laws are going to require that certain client information be reported even without client's consent. All right. So communicable diseases are reported to the health department or the CDC. That includes AIDS. Okay. Like I know in Virginia, the only time I've ever had to, well, me personally, the only time I had to report to the health department was for STIs. But I did have a case of mumps once, which I thought was really interesting. And I had a case of a child with salmonella. Okay. Salmonella in Virginia was reportable, so I had to report it to the health department. Vaccine related adverse reactions we report those to the Department of Health and Human Services. There's also another site, and I always forget what it is, that we can report vaccine related injuries. Criminal acts. So all states mandate reporting of rape cases. Some mandate reporting of injuries by gunshots or sharp objects like knives. Some also require reporting of BALs or blood alcohol levels above the legal limit, so that you have to look at your state mandates for that. But if you're working in an area where you're going to deal with this, obviously you're going to have that information. Any equipment related injuries. So when use of a medical device results in injury or death, it needs to be reported to your supervisor, and then they'll go on. When there is clear and present danger, okay. So this is when we were talking about earlier, about your impaired, coworkers, okay. they, if any professional misconduct, any client mistreatment needs to be reported. Um, Abuse and neglect of a child or an elderly a person. So I'm going to ask you this question. So as a nurse, you are mandatory reporters, right? Especially child abuse. We talk about child and elder abuse. Why okay, so what if I'm working in the emergency room and I have a woman comes in, she's been beaten and you can tell she was beat up, but she's not telling you she was beat up. Do we report abuse on adults?
Yes.
100% sure with that?
No,
Why
We
do
were
we do with the elderly, but not within the situation scenario that you just presented. Because
why? Go ahead.
I forgot. I learned in last term. I thought we did, but I was corrected.
Isn't that a
Last term, he said no because it's their right or something like that for autonomy.
So we only report when they're a child or older adults?
Elderly, yeah.
Elderly
Only
or
in only
or
elderly?
cognitively impaired, those
Yeah.
like more vulnerable populations. Jamia, you were going to say something. What were you going to say?
I said, isn't that a HIPAA violation?
So no, only because it's an adult, but this is where I want to go. So you have that woman that comes in, she's all beat up. Her husband did it, right? You can tell by the interactions, you can see, okay? But what happens if you call the police and the police come involved and they don't do anything and she has to go home with her abuser? What could happen?
They can
To
sue.
kill her before.
But
The violence can escalate.
but
Okay.
shouldn't
He can,
shouldn't we that at least report it or put it on the chart? No?
I don't know about putting it on your chart. You're going to have to check your hospital's policy.
Mm.
Okay. The thing is, though, the abuse can get worse. Okay. If he thinks that she said something, the abuse can get worse. Now, if you pull her aside and she wants help and that's different. But if she is not asking for help and she doesn't want the help right now, she just wants treatment for her injuries, all we can do is provide education and information. Here's the battered women's shelter number. Here's, what are some things that we can provide, because if she doesn't have a way out, you're sending her home with her abuser. Okay. So they have to want to get out, because you don't know, she might have kids at home, right? She may have kids at home. And, there's just, yes. So really, we focus on children and the elderly. We are going to offer as many resources as we can, but we don't also want to put her in any more danger.
And Professor, what happen if we don't report her? Because sometimes the patients doesn't talk because they are afraid of what can happen. But
Mhm.
let's say that we don't report that issue, and then the next day,
Yeah, what
God
will be the
forbid,
worst scenario?
God forbid, and that person got killed, and it was reported or was on the history of and that patient went to the hospital and nobody reported the abuse.
But she has
Are
the right to
we
say that she does not want you to report it.
okay? So are we protected in that way? Like I didn't report it
Yes.
because the
Yeah.
patient didn't
Yeah.
request assistance.
Yes. And yes, you are allowed to ask them to step away from the patient to talk to them. Okay. No matter who the abuser is or who the abusee is, that's probably not the best
Mm-hmm.
word. Okay. You want to separate. Absolutely want to separate. Doesn't matter if they're very young, very old, or somewhere in the middle. You want to separate them from their abuser. They're not going to talk to you in front of their abuser. They're not going to tell you what is happening in front of them. Okay. So that's going to be the woman that said, "Oh, silly me, I fell down the stairs." And you know that the injuries don't correlate to somebody falling down the stairs, okay? Or same thing with a kid. The injuries don't correlate to what the parents are saying. Yes, even the elderly person. Okay, separate them, make up an excuse why you need to separate. We need to take them to x-ray. You can't come in the x-ray room with us, so you need to wait here, right? So yes, absolutely. Okay, you want to talk to them. You want to get the information, but with those adults, we can't really do as much because they have autonomy, right? They have the right to make the decision regarding their care.
Okay.
I
That's
know. It
that's where
stinks.
that's where
100%.
that's
It
where personal ethical and professional ethical comes in. Like, do I report it or not report it?
I know it's hard. It's hard, because you know what these people are going through and you want to be like, I want to help you, but they have to make that decision because like I said, you don't know, they may have kids at home and they're not going to tell you anything because they need to get home for their kids to protect their kids, right? And then make a plan, but you can give them information, right? You can give them the number to a hotline. You can give them the number to a women's shelter, those kinds of things so that they have that information, right? So they can, when they decide that they can make, can get out of the situation, that they have that resource.
Okay.
I know it stinks, trust me. Um, other things with, with clients' rights, everybody has seen it, in the hospitals, even in your doctor's offices, you may have seen the patient bill of rights. So some of the things that, we have the right to as patients or your patients have the right to, because, we're patients too sometimes, right? High quality care, clean, safe environment, being involved in their care. That's 100%, right? They are the center of our nursing process. Privacy protection, help when leaving the hospital and helping with billing claims. Do they need DME? What kind of assistance do they need when they leave the hospital, right? Sometimes, patients can feel lost. They may not know like what to do. We're going to provide as much education as possible, right? Give them as much as we can. But, once they go home, they still may like, oh my gosh, I don't know what to do. I didn't ask these questions. I should have asked these questions. So they should have help, right? They should have, here's a number to call if you have questions. Here's your contact number for your primary care, whatever it is. Oops. HIPAA, talked about HIPAA a little bit. HIPAA, one of the big focus of HIPAA was privacy. So it's your Health Insurance Portability and Accountability Act. And it's, again, it's about protecting your patient's privacy, not sharing information with people that don't need to know the information. It's also not, if you're working in a hospital, it's not, oh, I heard my best friend's husband, sister's brother is in the emergency room. Let me look at their chart, right? You can't do that. But what you can do, is let's say that patient's discharging and they need their DME. You're going to call the DME company, you're going to order the equipment. Well, how do they know where to go? Okay. So obviously you're going to have to give them the patient's name. You're going to have to give them the address. You can also give them their insurance information. Okay. DME has to be able to bill insurance. Okay. And so they need to know if the equipment is covered, right? A lot of times too, if patients need DME and it's not covered by the insurance company, they may not have the money to rent it. All right. So their address, their name, their payer information is okay. HIPAA also requires that all covered entities have a designated privacy officer, right? So when you go to the doctors for the first time in a new year, right, you have to sign a new privacy practice, right? And that outlines the privacy practice for wherever you just went. It also requires that privacy officer. So if a patient or a client thinks that their privacy has been violated, okay, then you want to make sure that they have that privacy officer's information so that they can file a complaint with the privacy officer. The privacy officer will then do an investigation to see if their if their privacy has been violated. All right, we're almost done. Let's take a break. Be back at 7:45. Everybody still awake? All right. I said that and my dog's come running. I wasn't calling you. All right. So let's talk about client competency. Um, so excuse me. Client competency means that there's a difference. I'm sorry, let me rephrase. There's a difference between legal and clinical competency. Okay, so clinical or legal competency refers to a client that's 18 or older, that is a pregnant or married woman, a self-supporting minor, which those use, legally emancipated minors, or competent in the eyes of the law. Okay, incompetence is determined by the court. Okay, so the court can determine that somebody is incompetent. With clinical competency, this means that they are able to identify the problem, like why they went to the healthcare provider. My foot hurts, I have a stomach ache, my head aches. um, that they can understand the options for care and the possible consequences, and then make a decision based on sound reason, right? And they can, tell you what, how they can provide a sound reason based on what the option they desired for care. We do have different types of consent, okay? So general consent is for treatment obtained on admission. So you go to the doctor's office, you go to the emergency room, and in the check-in process, when you're, talking with the admission clerk or the, front desk person, they're going to have you sign consent. That just means that you give consent for that provider to treat you. Informed consent is different, okay? This is needed for any invasive procedures that are either therapeutic or diagnostic, like a surgery or an invasive test. And so they have to sign informed consent prior to any, any invasive procedure. And this informed consent means it's all the good, the bad, and the ugly, right? They'll tell you what the diagnosis is. If they don't know what the diagnosis is, maybe they're doing some more testing or a biopsy to determine what's going on. Okay. So the diagnosis, the suspected diagnosis, they need to know the purpose, the description of the treatment. And I will tell you, in some situations, especially with surgeons, they may send the client home with a video or a YouTube link, okay? And that website will describe the procedure and everything involved in it, and then they'll be asked to sign consent after that, okay? So like for my example, I had early onset cataracts because I didn't take care of my eyes when I was younger. Um, and so yeah, the doctor could have, I honestly, if he tried to explain it to me, even though I've read about it and done all this before, I probably wouldn't understand it. So he did that. He said, here's a video to watch. This is the procedure. And then after watching the video, I did have opportunity to ask questions and stuff, when I did meet with him before I signed consent. Want to know what the expected outcomes are, the benefits, any possible side effects or complications, any alternative therapies that are available. Okay, maybe I don't want surgery. What is something else that I can do? And those expected benefits, side effects, complications. Who's going to be performing the procedure? Okay, so if it's a planned procedure, like you've probably met with your surgeon, you know him, but that's usually not always the only person that's going to be in that surgery, right? They may have a physician's assistant or somebody in that surgery, another member of their surgical team, where you have the right to know who is going to be in there and performing the procedure. Prognosis if it's not done. Okay. Sometimes it's known, sometimes it's not. If they don't know what the diagnosis is yet, they may not know a prognosis. Answers to any questions. Okay. You never nurses witness informed consent, right? We don't give them any information. We just witness their signature. If they say that they don't understand something or they have more questions, you stop you go get that surgeon, that provider, and you have them come back and answer those questions. They also have the right, like I said earlier, they can revoke permission at any time. Okay. They have that right. Authorized consent, usually this is with kids. So parents can't give informed consent for their kids, right? Because, informed consent, right? That means that, they identify the problem, they understand the options for care, they can make a decision. So parents give authorized consent, okay? Meaning that we are allowing you to perform this procedure on our child, right? And most of the time it's under somebody under the age of 18, or, sometimes, other issues that they may be over the age of 18 and still under parental care. Talked about that. The next part of this is advanced directives. Okay. So the two types of written advanced directives are your living will and your durable power of attorney. Okay. And so a living will is not used to specify who's going to make healthcare decisions for you. This is you. Okay. You should do this while you're young and able-minded. Okay. So knock on wood, something happens. All right. And you have a living will in place. This is going to outline, if you're seriously or terminally ill, these are the things you want and what you don't want. So do you want IV fluids? Do you want tube feedings? Do you want blood transfusions? Do you want CPR? Okay. Do you want hydration, pain control, right? Other comfort measures. You outline these specifically in a document. Okay. On the other hand of this, okay, we have a durable power of attorney. A durable power of attorney is a document. It's valid in all 50 states, but you are naming a healthcare proxy. So again, if you're injured, unable, or have a terminal ill, whatever the reason is, you're unable to make medical decisions for yourself, this durable power of attorney identifies someone that is going to make those decisions for you. Obviously, this is supposed, needs to be someone that you trust explicitly, that you have talked about your wishes with, and that they're going to follow through with the wishes that you are, that you want. And trust me, I've been in healthcare long enough time that sometimes the people that they choose as their durable power of attorney don't always go along with the wishes of that person. So it has to be somebody that you trust explicitly. Oops, DNR orders. Okay, do not resuscitate order is an advanced directive. It is based on the Patient Self-Determination Act, and that gives the healthcare provider permission to write the order for a DNR. Okay, so whatever the reason is, okay, you don't want any resuscitative measures, you tell your doctor this. It is a legal document. It is a legal document that has to be filled out. And most, just, it's again, it's an informed decision. And anybody can have a DNR. You don't have to be older. And yeah, it has to be approved by the provider. Absolutely. The DNR is a very specific form. It requires signatures and witnesses. But yes, it has to be an order from the provider. And like there was I don't know if it was what's the word I'm looking for, like a fad, or like I don't know what the other word I'm looking for is, but you would see there are people that went and got DNR like tattooed on their chest and stuff. That's not a legal order. Okay. So if that person gets into an accident and they need CPR, guess what? They're getting CPR, because just because they have DNR tattooed on their chest, that is not a legal document. Okay. They have to have that legal document that says that they are a DNR. Otherwise, they're getting all sorts of life-saving measures. Okay. And I don't, like I said, I don't know if it was a joke, if it was true, like, I don't know, but that is not legal. Okay. That is,
It was true. It was a
was it
case
true?
that was true.
Okay. It wasn't going to be followed unless you have your DNR, in your wallet. Okay. Or if it said DNR, look in my wallet. Okay. And you have that DNR in there, then that would be something different. Um, Good Samaritan Act. So I will say this about the Good Samaritan Act. So the Good Samaritan Act is it stipulates that a person who renders emergency care in good faith at the scene of an accident is immune from civil liberty or civil liability for their actions while providing the care. Key word is here in good faith. Okay. You still needs to be within your scope of practice. Okay. Making sure that you're not causing any additional harm to that person. There's different verbiage for different states and Good Samaritan Acts. So you can always look in your individual state to see what the Good Samaritan Act and see what it says for your individual state. Oops. All right. And then the last part. So euthanasia, okay? When we look at end of life and death and dying, okay? We have what's called physicians assisted suicide and we have euthanasia. They are not the same, okay? Physicians assisted suicide and euthanasia are not the same thing, okay? Physicians assisted suicide refers to a provider that is going to give or provide the means for death. And it's usually a combination of medications, okay? Then the client will pick up those medications and then they will administer the medications themselves, okay? So they choose the how, when, where, why, whatever, okay? And there are a couple states that allow for physicians assisted suicide. Euthanasia is basically where the healthcare provider would act directly to cause that person's life. And so this always brings to mind Dr. Kevorkian. I don't know if anybody knows who Dr. Kevorkian is. Okay, but you can look him up. He was big one. He brought euthanasia, to the news, to the world, because that is what he was doing. I want to just point this out, okay? The American Association of Nurses, okay, does not allow, okay, for nurses to participate in euthanasia, okay? Absolutely guns against the code of ethics for nurses, okay? So we cannot participate in euthanasia. Okay, so any nurse participation in assisted suicide and euthanasia is strictly prohibited, according to the American Nurses Association. With that being said, let's talk about the difference between active and passive. Okay, active euthanasia is actions that speed up the process of dying. Sorry, it is actively ending a person's life. It's initiating the dying process. It is morally wrong, it is legally not allowed, and it is forbidden by your professional organizations. Okay. Let's talk about passive. This is a little bit different. Okay. With passive euthanasia, we're just not doing anything to preserve life. Okay. I often think of this as hospice care. Okay. You have somebody who has a terminal disease and they have decided that they are going to stop life-saving treatments. That would be passive euthanasia. Okay. It's just avoiding prolonging their life. And they're continuing through the process that allows or causes death. Okay. This is morally permissible. Okay. This is legally allowed and it is approved by professional organizations. Okay. So give a couple examples. Let's say you have a patient that's actively dying. All right. But you also can see that they are in a lot of pain. All right. And what do? You look in, you're doing your assessment, their pain is a 10 out of 10, but their respirations are a 9, and you have the morphine in your hand. What do? Do you give the morphine or do you not give the morphine?
No, no give.
What do you think?
Can we give another type of medication that doesn't?
So, all right. Let me look. Oh, can I repeat? Okay, yeah, absolutely. So you have a patient that is in hospice care, okay? They are, we've stopped all their life-saving treatments. All right. They're in 10 out of 10 pain. You have the morphine in your hand to give them the morphine, but their respirations are only a 9. What do? Give the medicine.
Yeah.
Yeah. In that situation, it is okay to give the medicine, right? The premise behind hospice is death with dignity and freedom from pain, okay? Giving the morphine is not going to directly kill them, okay? It is okay to give the medication. And I will tell you, this is yes, give that comfortable transition, okay? We don't want anybody dying in pain. We don't want them to be uncomfortable. We know that it, could potentially hasten their death, but it's relieving their suffering. And I know a lot of nurses that struggle with this. 100% know a lot of nurses, and I've struggled with this myself because I'm like, I can tell they're in pain, right? Because
If I give it, it's going to like practical stop.
right, it potentially can suppress their respiratory drive. But if I don't give it, they're going to be suffering, right? So that's the difference. The practice of administering pain medication that may hasten death and relieve suffering for a terminally ill patient is justifiable as long as the intent is to alleviate the suffering. Okay, the goal is to alleviate the suffering. And I will tell you, the morphine isn't what's going to kill them. Okay. What will happen is it may relax them enough, right? Because if you're in pain, you're very tense, right? You're using more oxygen, you're using you need more glucose, right? You need more energy because you're in pain. And giving them that medication just may relax them enough, but you're not killing them. Okay. Just remember, you're just really alleviating the suffering. Now, if you went in there and you were like, I'm just going to give you a triple dose of this morphine. Okay. That's completely unethical, right? As long as it's within the standard of practice, you're not going in there and you're doubling the dose or tripling the dose to give them their medication, right? The goal there, you're not killing them. You're just helping to relieve the suffering that they're experiencing. And I will tell you, like I said, a lot of nurses, they struggle with that. Because it's like, what do? But we don't want our patients to suffer. That's the biggest thing. All right. So just some little points to remember, as we close out. So again, personal liability, we are responsible for our own behaviors. Remember, student nurses held accountable to the same standards of an LPN. Um, the most common type of negligence in practical vocational nursing relates to action or lack of action, not what was intended to be done. So, example here would be the nurse who failed to report a critical lab to the provider, which resulted in injury. Talked about that earlier, right? Failure to report. Your best defense for the prevention of legal liability is developing a rapport with your client. Okay, the better your rapport, your relationship with your client, that therapeutic relationship is your best defense for legal liability. Also, LPN should be clear with the RN if something is not within their scope of practice, right? So again, that's where that Nurse Practice Act comes into play. Know what your Nurse Practice Act is. And then organ donation. I know this is kind of just random. Organ donation is a voluntary act. Okay. So this isn't something that you can be forced into. I know, what is it? Isn't it, when you get your driver's license, right? Isn't that where you do your organ donation, right? So you get to choose whether or not, right, you want to donate your organs. Now, if you have excuse me, excuse me, if you have a durable power of attorney, and you didn't stipulate whether you wanted your organs donated or not, then your your proxy can make that decision for you. But there's so much that can be donated. You don't have to donate your whole body if you don't want to, right? Like skin. I'm trying to remember my mom. What did I think she donated. No, she didn't. She had wanted to donate her eyes. That was always one of her big things. But she couldn't because towards as she got, well, she developed glaucoma, I think. Glaucoma or cataracts. I don't remember. Maybe it was cataracts. And she had surgery to correct it, but I think because of that they wouldn't take her eyes. Um, but I mean, everything. I feel like everything can be donated. Skin can even be donated. So lots of things. All right. Any questions for me? No questions?
I'm still hanging there if I report it or not for abuse.
I know, I know. It's a hard one. It's a hard one. It really is. I 100% like it is. That is a hard one because they're being hurt and they that they need the help, but they have to be willing to accept the help. Because otherwise we can put them in more danger. Now if it's a woman who is cognitively impaired, okay, that could be a different situation, right? We would be required to to report that. Um, but if they are of, sound mind, they have that right to say yes or no. Um, and what we do is we just provide the resources. We can give them as much information as we can so that, when the time is right for them, you know, they can, they can escape or, I hate the word escape, but so they can get out of the situation that they are in. All right. I know it stinks. Ugh. And now we're peds and geriatrics, so I've never the whole middle people. It's just a different situation. Um, but yeah, and I've had to call Child Protective Services a couple times in practice, and I mean even that's not a good situation. Um, but yeah. All right. Any other questions? Everybody's good? Yeah. All right. Don't forget, you have a next exam review is Friday at 4:30, I said. And then your exam is next Wednesday. And we will have class after the exam. I know, I'm sorry. But we will have class after the exam. So if you don't have any questions, you're free to go. I will see y'all next week. You guys have an awesome weekend and rest of your week. And I'll see you next Wednesday.
Thank you,
Thank
Professor.
Have a good
you.
You're
night.
welcome.
Bye. Good night.